Welcome to ICU Fellowship Prepcast. Hi, my name is Swapnil. And in this podcast series, we are going to talk about how to approach hot cases and discuss different templates and different real hot cases. So in this episode, we are going to talk about how to approach a neuro hot case. Often we see that candidates struggle to examine neuro patients, and the most common theme is lack of understanding of neuro exam along with lack of practice. So in this episode, I will share my approach towards neuro exam. So as we discussed in the last episode, the hot case is usually divided into three phases. One is outside the room, the second is inside the room, and the third one is again outside the room or the presentation phase. Now, when you are given a hot case question outside the room, in that first 2 minutes, the key information to process, first of all, age and sex of the patient. So how many years old, because that will have significant implications on how you present and package this case. The second one is the presenting complaint. In neuro exam, especially, this is very important because the presentation and the chronology of events and then the outcome will depend upon the initial presenting symptoms. And key things to note that the patient presented with neuro symptoms after trauma, after loss of consciousness, which is spontaneous, after some confusion as onset, and or patient presented with diagnosis of seizures to intensive care unit. And the next crucial information to note is how many days or weeks this patient is in your intensive care unit. Because again, that will have a significant impact on prognostication and also the way that you make your decisions or assessments in this particular patient. So in first 2 minutes, you need to process all this information, identify that this patient has obviously got a neuro problem. So you're going to start your clinical exam with neurology as a first system. So in that first 2 minutes, the key things to process, trying to see where this case is going. Now, if the patient is given to you is less than a week in intensive care unit, obviously that means the patient is currently in what I call it as acute phase, where either there are still ongoing investigations are happening, ongoing resuscitation or stabilization is happening with regards to ICPs, or it could be that in first week, we're still trying to gather as much as information from examination and investigation. So that's the kind of less than a week patient. And in that kind of scenario, it's hard to talk about the prognostication phase. On the contrary, if you're given that a patient has been in intensive care unit for more than 2 weeks, if that patient is already tracheostomized, then obviously that means this is a case where there has been significant challenges with neurological recovery and need to be considered and need to be presented with your opinion or your view on prognostication in this context. So that's why understanding how many days or weeks in intensive care unit is crucial. So once you step inside the room, your observation phase begins. Now, in that first 1.5 minutes, you got to, obviously, as I mentioned before, calm your nerves, try to absorb as much information possible in that environment, and try to kind of find the clues which will again help you to form a complete picture. The key things to notice. So usually I start with monitor. So key things to notice in the monitor, whether the patient is in sinus rhythm or whether the patient is in rapid AF. Whether this patient has got any extra monitors displayed on the patient monitor, such as ICP monitor. If it has been displayed, then what's the current ICP levels? Now, more than actual number, it's important to know the trend. And you are allowed to ask the question to examiner, has there any difficulty with regards to ICP control? And did patient require any ICP management? Or how's the trend with regards to ICP in last 24 hours? Because that's obviously significant and relevant to presenting case. most of the times, these patients will likely to have higher targeted map in order to maintain the cerebral perfusion pressure within that magic number of above 60. Once you notice the monitor and interpret the monitors, then you move on to the ventilator. Now, often in straightforward neuro cases, the ventilator settings are pretty standard. Either likely they are going to be still on SIMV and not taking any spontaneous breaths, especially with which the less than a week. If it's a more than 2 week scenario, often the patient might be on spontaneous ventilator mode and patient will be breathing on his or her own. So usually the ventilator is not a significant issue with regards to neuro cases. And usually you just notice and mention that which mode the patient is currently on. And is there any issue that you observe with regards to compliance and resistance of the lungs? Now, once you get ventilator out of your way, next one to focus is on infusions. Now, in regards to infusion, there are multiple clues and that you need to keep in mind. The first of all, patient might not be on any infusions at all, especially in the scenario where the patient is in intensive care unit for more than 2 weeks. And that clearly gives you a signal that this patient is not waking up because patient is not on infusion. The intensivist is trying to stop all sedative agents and in order to assess the neurology. And often more the number of days in ICU without sedation, that's going to be a problem. And again, here you are allowed to ask a question asking for how many days the infusions have been ceased for. On the contrary, sometimes you see the patient with heavy sedation and sometimes with or without paralyzing agents. So a patient might be on fentanyl or morphine and midaz infusions with a double strength, cisatracurium infusion, or any other neuromuscular blockade agent such as vecuronium infusion. And in that case, it is given that this patient has been having issues with ICP management, or in cases of status epilepticus, this patient is requiring heavy sedation in order to achieve the burst suppression. So heavy sedation with or without paralysis gives you again the clue that there has been some issues with underlying severity of the brain injury. Another infusion that you might notice is noradrenaline infusion. And as I mentioned before, in the monitor section, that these patients, we're trying to keep their MAP slightly on a higher level in order to maintain the cerebral perfusion pressure above 60. Often we'd like to drive the higher blood pressure with the use of noradrenaline. Having said that, that might not be always the case because often the more these patients stay in intensive care unit, they're also at risk of developing septic shock. So NORAD infusion can be used in order to manage the blood pressure and manage the shock. So don't assume that NORAD infusion is always going to be used to maintain the CPP. But in a context, it's less than a week and ICP monitor is in place with the CPP showing 70, I guess NORAD, and the blood pressure is, if it's like 130 or 140 with the 1 or 2 mils of NORAD, often the case is that's used for maintaining the CPP. Another significant infusion to note is nimodipine infusion. And again, that's a clear giveaway that this patient has suffered from subarachnoid hemorrhage. There is no brainer in that because usually we don't use nimodipine infusion for any other pathologies. Now, another important thing to note or infusions wise is to look for any particular anti-epileptic drugs hanging around. Often might see a bag running labeled as levetiracetam or Keppra. Again, that indicates that this patient is either on anti-seizure prophylaxis or is getting actively treated for seizures. And last but not the least, another infusion that you can think of or it might see is the hypertonic saline. Now, various units have different practices in what concentration they use and how much infusion rates they use. But often the two commonly used infusions in intensive care setting in Australia and New Zealand are 3% hypertonic saline and 20% hypertonic saline. And again, you can ask here how many days or how many hours this infusion is running for, and when was the last time the sodium was checked, and what's the current sodium, because that will also help you to then decide about are you going to continue with hypertonic saline or not. Now that's about the infusions. Now, once you finish your monitor, ventilator, and infusions, then it's time to just step back and then look for any other devices which are attached to the patient. And it's important to notice them and mention to examiner or keep it to yourself, but then interpret in your mind, what does that device mean in this context? Often commonly seen devices include either EVD or Codman for ICP monitoring. Especially if you see EVD monitoring, usually it will have some other relevant information that you need to think about. The first and foremost is at what level the EVD is currently at. Is it at 5 centimeter, 10 centimeter, 15 centimeter, 20 centimeters? Lower the value, that means obviously patient is still having a lot of issues with ICP. So once the ICP is settling, then we start increasing the levels of the EVD in order to reduce the drainage. So if the EVD is already at 20 centimeter of water and it's not draining much, that means obviously it's in a more of a stabilization phase. Sometimes EVD is constantly open versus it's intermittently open and closed. So that's another observation to note. And also look at the CSF color, and you're also allowed to ask for the results of the CSF sample, which was sent recently, in order to rule out any signs of ventriculitis. So when you see EVD, make sure that you spend some extra time to analyze and interpret those numbers and that information. Now, once you finish all the observation phase, make sure that then you start with your neuro exam as the primary system. When you walked in the room, even before you start observation phase, even if the patient is unconscious, make sure that you go and greet the patient and then look around, come back, and again reintroduce yourself and say, for example, Mrs. Smith, Swapnil, ICU doctor, now I'm going to examine in depth. Often there is a confusion about what to do with neuro exam, where to start, how to start, and what things I should do, what things I shouldn't do. Now, neuro is actually pretty simple. It's almost like a mathematics formula. So if you follow that kind of structured template, usually you can't go wrong. And that's why I usually separate neuro exam from the other patients or other exams, because in neuro, if you follow the set patterns, you're very unlikely to go wrong. So you're supposed to start your CNS exam, and usually you got 4 to 5 minutes to complete your thorough neurological assessment. And if you read any clinical examination book like Taliokonar or Jinson, so every single book will have a clear pattern described in it. The first and foremost is check responsiveness and check for higher functions. Now, often, as I mentioned, based on the level of sedation, assessing the responsiveness might not be possible. So, for example, if the patient is heavily sedated and paralyzed, there is no point in giving painful stimuli, because patient is heavily sedated and paralyzed, and causing the pain in that scenario will be considered probably detrimental to passing the exam. So check responsiveness when it's appropriate, and it's done in a gradual escalation technique. So first of all, tap on the shoulder, ask patient to open eyes and follow some simple commands. If that's not possible, then gently tap on the shoulder, then ask to follow the simple commands. If that's not possible as well, or patient is not doing anything with that, then you are allowed to proceed with painful stimuli. Now, it's important when you're applying the painful stimuli. Now, there is a lot of debate about where you should apply painful stimuli. Usually, I go with the supraorbital ridge, and that's been documented and recommended in many textbooks. So when you apply the supraorbital stimuli, there are two things you're looking for. One is obviously, is there any response? And that will help you to determine what's the motor level of this patient. Is this patient is localizing, withdrawing, flexing? So that helps you to classify the motor response. But also, it helps you to identify the symmetry. Is there a problem with the symmetry? So if you're applying the painful stimuli on both supraorbital ridges or one at a time, you are trying to look for any symmetry or asymmetry. So if patient moves both upper limbs, that means obviously there is no any focal neurological deficit on either upper extremity, versus if the patient is weaker on the left side and he's just moving to the right side, that again, it describes that there might be a significant weakness on the or her left side. So, and that helps you to then, first of all, assess the responsiveness, but then it also helps you to assess the patient GCS. Often in exam, it is expected for you to quantify GCS in a very clear manner. Patient GCS cannot be ranging between 5 to 8 on a single snapshot examination. And you need to identify clearly the different components of GCS. So what's the score for eyes? What's the score for verbal response? And what's the score for the motor response? So make sure that you assess, quantify, and present GCS in a very clear manner. So patient GCS was 8 and it was E2, V1, M5. And that is very important. Now, once you finished your assessment of responsiveness, if patient is conscious and awake, and then you might assess patient's speech, whether there are any features suggestive of aphasia or dysphasia. But if patient is intubated, you usually cannot assess any of those comprehension and speech assessment. So in that case, you move on to the next stage, which is the cranial nerve functions. Now, this is another area where candidates either get confused or they go wrong. Intubated patients versus non-intubated patients. So cranial nerves, I should examine if the patient is intubated. So cranial nerves which can be assessed in intubated patients include the first and foremost cranial nerve 2 and 3, optic nerve and oculomotor nerve. And how do you assess that? By simply checking the pupillary light reflex. Before you do that, always explain to patient, even if the patient is unconscious and sedated, that what you're doing and what you're looking for. So always I will say, Mr. Smith, I'm going to shine light in your eyes now and assess how's your eyes react. So shining the light on right side and then left side, one at a time, giving adequate time between two stimuli. What we're looking at is consensual light at the same time. The next one is the corneal reflex, which basically involves testing the cranial nerve 5th and 7th, which is trigeminal nerve and the facial nerve. The simple response is when you touch the patient's cornea, the eyes should blink. And it is usually carried by the sensory branch of the trigeminal, and the efferent is your facial nerve, which is orbicularis oculi, which leads to blinking. The technique wise, often people go wrong because they touch the sclera and not the cornea. And that's where it has to be tested properly. So take a clean gauze piece, make sure that you're not touching with the same gauze piece on the other side. You can make or use the different ends of the same gauze piece, but make sure that you don't contaminate by using the same end on the both sides. So that's your corneal reflex. The other reflex you can test in unconscious intubated patient is either Doll's eye reflex or the oculocephalic reflex, which is usually carried by vestibular ocular nerve. And then the efferent will be your 3, 4, 6. So oculomotor, abducens, and trochlear. In simple way, when you turn the head, the vestibular apparatus is activated via 8th cranial nerve, which leads to eyes moving in the opposite direction. And that's a very simple oculocephalic reflex. The important thing to note here that it is contraindicated in patients whose C-spine is not cleared. Now, you can do cold caloric test, especially when you're testing for brain death, but usually we don't perform outside that setting. Next is moving into the gag reflex. So that's now we are moving into the cranial nerve territory 9 and 10, where you can check either gag reflex and then again you can check cough reflex. Now, again, testing the gag reflex in the intubated patient can be extremely challenging because ideal way to do is test one at a time, and then you have to use a tongue depressor and take a large cotton bud and then stimulate the uvula on each side and then look for contraction of the soft palate, which is very hard to do with the intubated patient. And often examiners will understand that if you can't test the gag reflex, that's okay. But you need to then check cough reflex because you are trying to test the lower cranial nerve, which are 9th and 10th. Sometimes checking all reflexes might not be feasible, and you can mention that and then proceed with the cough reflex. So usually in the 1, 4, 11, and 12 are the nerves which are missing when you test the cranial nerves in intubated patient. And with the practice, it becomes very easy to do this exam within first couple of minutes. Now, once you finish the cranial nerve, next one is to move to the motor assessment. The motor assessment involves basically assessment of tone, power, and reflexes. And when you assess for tone, power, and reflexes, make sure that you assess both sides simultaneously, like one at a time. But usually, if you're testing for upper limb, you test right and then left. Going to the lower limb, again, test right and left. So in terms of the tone, another important thing with assessing tone and power is always you do one side at a time, but also you do proximal and then distal. And you should be able to comment whether the patient tone is hypotonia, is it hypertonia, or is it normal tone? And that's very important to check. Now, in terms of the checking the reflexes, again, important to go like in a structured manner. And again, start with upper limbs, bicep, C5, C6, then testing on the tricep, that is C6, C7, and then usually testing the brachioradialis, which is again predominantly C6 and C5, and then going into lower limbs with knee jerk, ankle jerk, and also testing for Babinski or plantar reflex. Now, understand that plantar reflex is a superficial reflex, while other reflexes are deep tendon reflexes. What is important and what is expected at your level is to the pattern that you're seeing based on your assessment of tone and reflexes. Is it upper motor neuron lesion or it is a lower motor neuron? That's really important point. So once you finish your reflexes, you check power. And in terms of the power, you look for a symmetry, proximal versus distal. And really need to practice this, especially in the patient who is conscious and able to obey command, because in unconscious intubated patients, you really cannot assess power properly. Obviously, you can figure it out whether, so assessing the power or commenting that power is important. And if you're able to assess the power in a conscious patient, then you have to interpret in a MRC scale, which is grade 1 to grade 5. Now, once you finish the motor examination, the two examinations left within the neuro exam are sensory examination and then the assessment of cerebellar function. Now, again, these exams might not be possible in most of the ICU patients because most of them are either unconscious, unable to communicate, and they won't be tell you. So sensory function is very, very difficult to assess. And if you manage to assess, then it's obviously going to take a lot of time. Similarly, with cerebellar function, if the patient is not conscious and cooperative, it's very difficult to do any cerebellar function. And often the early sign to suggest that whether you need cerebellar function assessment or not is whether the patient had any nystagmus, either eyes. So these are the kind of simple structural patterns for examining neuro case. Now, another struggle for candidates is to how to summarize. One thing is you examine the patient, you got the findings now. So what to do with those findings? And again, as I mentioned before, it's very important to then interpret or the package those finding in some sort of meaningful presentation. Now, if you are noticing hemiplegia or weakness on one side of the body, then you need to really start thinking about where the lesion is, because usually it results from unilateral lesion of either brainstem, internal capsule, or cerebral cortex. Obviously, if it's a brainstem lesion, that will result in the crossed hemiplegia. And say, for example, if it's a left pontine lesion, that will lead to left facial weakness of lower motor neuron type with a right-sided hemiplegia. And the pupils will be usually pinpoint with pontine lesion. So once you see those three different things, you package them and say, most likely, I think the lesion is in left pons. Similarly, if the lesion is in left midbrain, that will lead to left-sided oculomotor weakness with right-sided hemiparesis and right-sided facial weakness, which is usually a upper motor neuron type. Now, lesion above the level of brainstem usually result in uncrossed hemiplegia. So left frontal capsule lesion will lead to right hemiplegia and right facial weakness, which are both are going to be upper motor neuron type. So that's the kind of level of interpretation is expected. And sometimes some of the neurological examination will not make any sense because the pattern will be very different. There will be some, then in that case, you're allowed to say that, to be honest, this neurology pattern does not make sense or does not fit into one particular territory or one particular lesion. I need probably more information regards to his imaging. And often that's the case because especially when you get the patients with cerebral metastasis or subarachnoid hemorrhage, usually you get this diffuse damage, which results into non-typical pattern of neuro exam. And that's okay, because in that case, you are allowed to say that this pattern doesn't fit either in typical upper motor neuron palsy or lower motor neuron palsy. And often in ICU, if the patient is staying in more than 2 or 3 weeks, critical illness, polymyopathy, and polyneuropathy sets in as well. And in that case, interpreting these findings can be really challenging. Then the examiners will show you findings of CT scan and MRI brains, and be prepared to look at those scans. One of the challenges that candidates face is to sometimes narrow down the diagnosis very quickly and just be flexible to entertain a different idea of differential diagnosis, especially within the context of neuro. It could be cerebral metastasis or bleed within the intercapsule. It could be cerebral sinus thrombosis leading to bleeding in the brain parenchyma. So it could be anything. So that's why it's important to keep your mind open with regards to differential diagnosis. After you finish the neuro exam, then the second system to look for is a cardiovascular examination, then respiratory, and then abdominal. Again, in the patient with the stroke, have to do cardiovascular exam and look for murmur or any features of stigmata of endocarditis, or any features of cardiomegaly or carotid bruit. Respiratory system is also important because with sometimes subarachnoids and you do get APOs and aspiration pneumonia. So every single examination is important, but in just sequencing wise, it's always a neuro for cardiovascular second, respiratory third, and then abdominal. So when you come out of the room, once you have analyzed the information that you were given, that what you observed at the bedside, and then once you examined, so then it's important to now package that information. And you're allowed to then say that based on my clinical examination, probably it's not clear that where the lesion is. And I will probably need information with regards to imaging, which will involve CT brain looking for, MRI brain looking for, EEG looking for. So always make sure that you add those things. And coming back to the presentation, it's again, build your hooks. So present your findings for each exam, interpret them, then kind of try to formulate the issues that you identified, then address the question that examiner initially asked you, and then have a meaningful discussion around, okay, from this point on, what extra information do I need in order to make my plan for the next 24 hours? And again, in neuro case, what examiners are looking at is that whether you are taking that extra leap to talk about prognostication. Another interesting scenario will be if the patient is having issues with the raised ICP. Examiners are looking, if this patient continues to have raised ICP, will you be committing to decompressive craniectomy? What's your opinion about those interventions? And what will you tell to the family if you have to offer decompressive craniectomy? Own that this patient is yours. You are looking after this patient from now on, and what decisions you will make in the best interest of these patients. So that's for today's episode. We'll be back in again month's time with another hot case series. Till then, goodbye and have a nice time.